Good morning, everyone. My name is Angela Hung. Just a brief introduction of myself. I'm currently practicing within the Hazardous Area Response Team, or also known as a heart paramedic for the London Ambulance Service. This presentation will discuss the management surrounding distributive shock secondary to anaphylaxis, with aim to reduce gaps in knowledge among practitioners in the ambulance service. So, what is distributive shock? Distributive shock, also known as vasodilatory shock, is one of the 4 classifications of shock that causes inadequate tissue perfusion. Other classifications include cardiogenic, obstructive, and hypovolemic shock. In distributive shock, systemic vasodilation leads to reduced blood flow to organs such as the heart, brain, and kidneys, causing damage to these vital organs. Inadequate tissue perfusion occurs due to the loss of vasomotor tone in the absence of hypovolemia and cardiac dysfunction. Distributive shock is caused by various etiological factors, including sepsis, anaphylaxis, neurogenic, and endocrine abnormalities. These conditions, in particular anaphylaxis, lead to significant vasoplegia or loss of vasomotor tone in the microcirculation, which in turn results in tissue hypoperfusion. Just to understand the context of distributive shock secondary to anaphylaxis, I'll briefly touch on the pathophysiology of anaphylaxis first. In the immunologic mechanism, immunoglobulin E binds to the antigen, whether that be food, medication, or an insect bite. Next, antigen-bound IgE molecules attach to the surface of high-affinity IgE receptors on mast cells and basophils. When exposed to this antigen, mast cells and basophils release a cascade of mediators, including histamine, that results in physiological changes of systemic vasodilation and increased vascular permeability, which is the main cause of the fluid shift from the intravascular to the extravascular space. Histamine is a key mediator of anaphylaxis and has a strong correlation to symptom severity. The physiological changes also include bronchoconstriction and increased mucus secretions. The non-immunologic mechanism involves direct degranulation of mast cells and basophils. Inflammatory mediators have a significant role in the development of distributive shock. Systemic vasodilation and capillary leak are induced by inflammatory cytokines that are released in septic shock. Additionally, in anaphylaxis, the systemic release of histamine has a very similar effect. In distributive shock secondary to anaphylaxis, systemic vascular resistance is decreased due to this histamine release. Additionally, there is an increase in the synthesis and release of prostaglandins, which further increases vasodilation. The pathological redistribution of the absolute intravascular volume creates a state of relative hypovolemia. Decreased systemic vascular resistance causes compensatory responses, including increased cardiac output and tachycardia. The decrease in systemic vascular resistance leads to a decrease in preload, which may impair overall cardiac output. Clinical features for anaphylaxis include respiratory issues, cough, wheeze, dyspnea, and hypoxia due to bronchoconstriction, and angioedema and stridor due to inflammation. Neurological impairment sees altered mentation and confusion. Digestive features include nausea, vomiting, abdominal pain, and diarrhea. Skin changes occur, including urticaria, flushing, and mottling in late stages of shock. Finally, cardiovascular features include tachycardia, syncope, increased vascular permeability, and vasodilation, which leads to hypotension and distributive shock. Pulse pressure is seen to widen, capillary refill is delayed, and extremities are warm. As always, the physical examination should begin with a primary survey evaluating the airway, breathing, and circulation. A rapid head-to-toe examination must be performed, and a thorough cardiorespiratory examination should be undertaken. Visual inspection of the face, neck, and chest should assess for angioedema, dyspnea, hoarse voice, stridor, dysphagia, and skin abnormalities, including mottling and cyanosis. Examine the neck for jugular vein distension, tracheal deviation, and the chest for signs of respiratory distress, intercostal recession, abdominal muscle use, and symmetry of chest rise. Determine the strength of radial pulses, assess the skin for temperature, whether it is cool or warm, and assess capillary refill. Auscultate the lung field for additional sounds and reduced air entry. Monitoring should include a full set of observations, which are blood pressure, pulse, level of consciousness, temperature, oxygen saturations, blood glucose level, standing blood pressure, and mean arterial pressure. Identify any signs of hypotension, tachycardia, pallor, decreased level of consciousness, confusion, bradycardia, pyrexia, and hypoxia. Postural hypotension should also be assessed through a standing blood pressure, if permissible, depending on the patient's condition. Physical examination can be limiting in identifying the source of shock. However, some physical findings can be suggestive of underlying etiology. Ambulance Victoria clinical practice guidelines include an acronym known as RASH, which stands for respiratory distress, abdominal symptoms, skin or mucosal symptoms, and hypotension to aid patient management. When 2 or more rash symptoms are evident, plus confirmed exposure to an antigen, anaphylaxis criteria is met. The 3 windows of the body is a concept that can be used to spot clinical signs of shock by looking at the windows into the body's perfusion. This involves examining the peripheral window, whereby skin is assessed for pallor, cyanosis, discoloration, and cool temperature. The renal window looks at reduction in urine output. And lastly, the neurological window highlights any abnormal behavior, confusion, disorientation, or altered mentation. Due to the time-critical nature of anaphylaxis and distributive shock, this can be a really efficient and effective way to assess your patient for signs of shock. Hemodynamic stability should be optimized in order to prevent cardiac arrest, which can be achieved through pharmacological events. The first line of treatment for anaphylaxis is 500 micrograms of intramuscular adrenaline to counteract the pathophysiological changes. The mechanism of action for adrenaline makes it the pressor of choice for distributive shock caused by anaphylaxis. Australian Capital Territory Ambulance Service intensive care paramedics administer an IV adrenaline infusion of 1 milligram in 500 ml normal saline titrated to response. If the patient is unresponsive to both vasopressors and fluids, this could indicate adrenal insufficiency. Activation of alpha-1 adrenoreceptors induces vasoconstriction to reduce hypotension and further distributive shock. Activation of beta-1 adrenoreceptors induces increased cardiac contractility and heart rate, which in turn increases cardiac output. Activation of beta-2 adrenoreceptors induces bronchodilation in order to reduce respiratory distress. In addition, it stabilizes mast cells, reducing degranulation and release of inflammatory mediators. In regards to the pharmacokinetics of adrenaline, the onset of action for IV administration is 30 seconds. Intramuscular administration is 30 to 90 seconds. Peak effects for IV is 3 to 5 minutes, and IM is 4 to 10 minutes. Oxygen is used in aerobic cellular respiration to produce energy for normal function of all cells. Aim in treatment is to optimize oxygenation the target to greater than 94%. In regards to pharmacokinetics, again, the onset of action is immediate, peak effects are variable, and duration is less than 5 minutes. Sodium chloride is administered to improve end organ perfusion and oxygen delivery through replacing the volume in the intravascular and extravascular spaces. The dosage is 250 ml titrated to effect with a maximum dose of 2 litres. Onset is immediate, peak effect is variable, and the duration is also variable. Salbutamol activates beta-2 adrenoreceptors to induce bronchodilation by smooth muscle relaxation in the lungs. It also has minor chronotropic and inotropic effects in the heart and enhanced movement of potassium into all cells. The dosage is 5 milligrams, nebulized with 6 to 8 litres per minute of oxygen. The onset is 2 to 5 minutes. Peak effect is variable, and the duration is 1 to 4 hours. Ipratropium bromide blocks muscarinic acetylcholine receptors, resulting in decreased smooth muscle contractility, bronchodilation, and a reduction in respiratory tract secretions. The dosage is 500 micrograms, nebulized, again with 6 to 8 litres per minute of oxygen. Onset of action is 3 to 5 minutes. Peak effects are less than 2 hours, and duration is 2 to 6 hours. Hydrocortisone acts through glucocorticoid receptors to inhibit inflammation, suppress the immune system, and influence use and storage of glucose. The dosage is 200 milligrams IV or IM. Onset of action is 1 to 2 hours, peak effects is 2 to 4 hours, and duration is 6 to 12 hours. Magnesium reduces calcium influx into cells, promoting smooth muscle relaxation and a reduction in cardiac muscle contractility and excitability. Our dosage here for magnesium is 1 to 2 grams IV. The onset is immediate, peak effect is variable, and the duration is 1 hour. The administration of glucagon binds to the receptors in the liver, increasing the breakdown of stored glycogen and promoting the release of glucose into the circulation. Myocardial contractility and heart rate is increased through bypassing the beta adrenergic system. The dosage is 1 milligram. Onset is 5 to 30 minutes. Peak effect is 10 to 30 minutes, and duration is less than 2 hours. Now moving on to relevant investigations. An ECG can identify arrhythmias or ischemia that can mimic the clinical presentation of distributive shock. Further relevant investigations include chest X-ray to identify pneumonia, pneumothorax, or pulmonary edema. Point-of-care ultrasound testing using the rapid ultrasound for shock, also known as the rush examination, can be used for patients without a clear cause of undifferentiated hypotension. The pump, tank, and pipes are examined to assess the heart, vascular volume, and integrity of the vessels as underlying causes of hypotension. A full blood sample should be taken, including lactate and blood gas, which could reveal evidence of sepsis. Blood tests for histamine and tryptase can be key in diagnosing anaphylaxis as the cause of distributive shock. Distributive shock secondary to anaphylaxis is a time-critical emergency that has high morbidity and mortality if not recognized promptly and managed with early interventions. Practitioners should be vigilant when determining the triggering event that caused the fluid shift in distributive shock, which in this case is anaphylaxis. Therefore, concurrent treatment for anaphylaxis and distributive shock should occur. Consideration should be taken for mode of transport for conveyance time. For example, rural locations with long ground conveyance should consider helicopter conveyance or fixed wing, whereas metropolitan ambulances might benefit from shorter conveyance times by ground. Early conveyance to definitive care can maximise patient outcomes, as these patients can often be critically ill and require intensive care interventions and monitoring. Emphasis is definitely on treatment of the underlying etiology of distributive shock. Distributive shock secondary to anaphylaxis presents a complex clinical picture. Therefore, as a senior practitioner, it is paramount to demonstrate effective leadership when dealing with multiple demands on scene. Crew resource management should be utilised to ensure best practice is maintained while staff on scene remain supported. Crew resource management, or CRM, can be defined as a management system with aim to maximise use of all available resources, whether that be people, procedures, and equipment, in order to advocate patient safety. The elements which comprise of CRM aim to draw on a wide range of knowledge, attitudes, and skills, inclusive of communication, problem solving, situational awareness, and teamwork, to ultimately come together and achieve a common goal. CRM acknowledges human factors can result in the crew's inability to respond appropriately in high-pressure situations. The treatment of distributive shock and anaphylaxis is multifaceted and heavily involved. Therefore, patient management must focus on maintaining situational awareness to recognise the factors and environments that can affect patient safety. This can be achieved through sharing a mental model of the treatment plan for this patient group with the entire team, so that everybody is on the same page. Clear communication channels with the team can heighten situational awareness and further maintain teamwork to ultimately reduce poor decision making that could result in patient deterioration. CRM depicts the importance of reducing task focus and heightening cognitive and interpersonal skills to maintain an efficient scene. Thanks for listening, guys. This is just my reference list here. It's 2 pages long. Thank you.